I'm going to get started. My name is Benjamin Day. I'm the Director of Organizing for Healthcare Now, which is a national single-payer advocacy group. And I'm joined by Steffie Woolhandler. Steffie is a professor at CUNY School of Public Health at Hunter College, and she's also a visiting professor at Harvard Med School. And she was one of the co-founders of Physicians for a National Health Program. So what we're here to do today is to talk about Medicare, which is our only universal health care program which covers seniors over the age of 65. And Medicare is a complicated symbol for those of us who are trying to extend universal health care to everyone and make comprehensive care a right for the whole country. It is our only universal publicly financed program, and single-payer health care, which would make for everyone, is sometimes called improved Medicare for all. And yet, while universal Medicare is not totally comprehensive, it leaves many seniors unable to afford all their costs. And even so, even though it doesn't cover everything, it's not totally comprehensive, Medicare is facing a financial crisis, and it faces sort of rapidly rising healthcare costs. And the reason we're doing it now is that Medicare was signed into law in 1965 on July 30th. So the anniversary of Medicare is coming up shortly. It's going to be the 28th year of Medicare next month. And it's sort of a time when we do single-payer actions around the country to try and fight to extend Medicare to everyone and to make health care right. So between the two of us, I think we're going to argue that the current proposals that are floating around Congress that are sort of the dominant proposals right now to try and fix Medicare, that is to make it affordable to the government and to taxpayers, are really totally inadequate. That they mostly involve cutting benefits for seniors, or they involve trying to slash payments to providers, which has been difficult. And we're going to argue that actually expanding Medicare to everyone and making it comprehensive would actually make Medicare itself and health care for seniors both financially sustainable, and we could cover all seniors with comprehensive coverage and solve those problems of coverage and access that seniors face right now. So ironically, we may have to expand Medicare to save it in the future. And we're sort of talking here about what would single-payer health care look like in its impact on seniors' access to care. So I'm going to give some very minimal background to sort of the financial crisis that's facing Medicare. And then Dr. Woolhandler is going to take over and go much more into depth about what's right and what's wrong with Medicare and what we can learn from how single-payer systems in other countries affect seniors' access to care compared to what we have here in the United States under Medicare. So very briefly, starting, I believe, in 2008, our Medicare program, which is, again, universal health care program, publicly financed for seniors, started facing deficits, annual deficits, where its costs were higher than its income, higher than its expenditures. And you can see in this graph that even though the gap has sort of been growing slightly each year, it's been running down the assets in the Medicare Trust Fund, which is what covers hospital care for Medicare. And in 2009, the Medicare trustees released a report which essentially projected that Medicare would run out of money, that the trust fund would be insolvent by 2018, which led to a bit of a panic. And since then, two things have been done. One is that Congress has tried to slash payments to healthcare providers commonly, and this has been very politically difficult to do. They've actually created a schedule of reducing payments to providers that has been overridden every year by Congress. The Congress has basically slashed payments to providers so that it increases by 0% or 1% or less each year. So the payments have been rising much less than for private health insurance. In addition to that, the Affordable Care Act, which was passed in 2009, 2010, raises new revenues to try and increase the payments that go into the Medicare system, all designed to avert this, the trust fund sort of becoming insolvent in 2018. But the bad news is that even with all of those things, even with keeping provider payment increases to zero, practically to zero, and the new revenue that was brought in by the Affordable Care Act, the Medicare Trust Fund, this is from the latest trust fund report just this year, 2013, is still projected to be exhausted by 2026. And that's sort of with an optimistic cost projection. It could run out as early as 2019, which would mean that all of this work, which was very politically difficult, essentially bought Medicare, a few more years of solvency and maybe no more years of solvency, depending on how the cost trends actually play out in practice. The result is that Medicare is taking up a larger and larger chunk of our federal budget, of the congressional budget, and it's edging out other spending items that we might want to spend on. And in fact, this makes Medicare to a significant extent like every other private insurance plan and every other public insurance plan. Although Medicare, as you're going to see later in the slideshow, is more efficient than private health insurance. It covers the same things for less and has rising costs that are not rising as quickly as for private health insurance plans. It is still part of the same healthcare system because Medicare is not a true single-payer system. The Medicare does not have the ability to reduce and to cut administrative waste that's faced by healthcare providers because it's just one of many insurance plans that hospitals and providers and doctors face. And so most proposals out there to try and address this fact that Medicare is taking up more and more of the budget, and again, we can look at this for all healthcare spending across the country, essentially. Healthcare is taking up more and more of household budgets every year. It's taking up more and more of employers' business budgets. It's taking up more and more of every municipal budget and state budget. And that's a combination of private insurance rising out of control, other public insurance plans like Medicaid as well as Medicare. In essence, although Medicare is better off because it's a public insurance plan and it has less administrative overhead waste, it does more to control costs. It pays providers a little bit less. It does more to sort of set rates for providers. It is roughly in the same boat as our whole healthcare system in that it has unsustainably rising costs when we're looking at the long term. So this is just a graph showing how unsustainable our healthcare system is as a whole. You can see this is a complicated graph because it has a lot of different lines, but the only important thing to know is that the United States healthcare cost is that black line on the top, and all those other colored lines are other developed nations and how much they spend, either per person or looking at healthcare as a percentage of our total economy. And you can see that we are such an outlier. We spend almost twice as much as the next highest spending country, and our costs are rising much more rapidly than other countries. And another scarier way to look at this is if we were to take our healthcare system out of the economy and treat it as a separate country, it would be the sixth largest country in the world, about the same size as the entire economy of France, smaller only than the U.S., China, Japan, and Germany, bigger than the United Kingdom. So what we're going to talk about here and what Dr. Woolhandler is going to go more into depth about is what's behind this crisis of cost for Medicare and for the rest of the healthcare system. How can we address? How has Congress been attempting to address the crisis of costs facing Medicare, and looking to other countries who have had better luck sustaining and expanding coverage for seniors? What can we learn from those systems, and what would a single-payer healthcare system look like for access to seniors care? So I'm going to hand the mic over to Dr. Woolhandler and let her take it away.
Thanks, Ben. Well, Ben has sort of covered what's right about Medicare. I think many of you know what's right about Medicare. Prior to the passage of Medicare, about half of seniors had no private health insurance, and many seniors really couldn't get the care they needed. And now, once you turn 65, you know you can get some insurance. So obviously that's something that's very right about it. Again, as Ben pointed out, there is a systemic problem. Medicare costs are going up and private insurance costs are going up. But if you look at the two lines, Medicare in yellow and private insurance in blue, of what's happened to spending in the last 30 years, yes, Medicare cost has been going up 2,200%, if you will, but private insurance has been going up even faster. So, yes, there's a crisis for Medicare and for the private sector, but Medicare has done a somewhat better job than U.S. private insurance in terms of overall cost control. Medicare has become increasingly important to Americans because retiree coverage, which used to be quite common, back in the late 80s, about two-thirds of all retirees got some health benefits from their former job. really not the case anymore. We're closer to about 1 out of every 4 retirees having any health benefit coverage, and 3/4 of retirees depending entirely on Medicare if they're going to have insurance at all. Of course, there's a whole lot that's wrong with Medicare. The biggest issue is that the coverage of Medicare is incomplete. It's full of gaps, deductibles, and things that the recipient has to pay. When we look at how much American seniors are taking out of their pocket to pay for health care, that's been going up pretty steadily since the mid-1970s. By 2000, the average senior was spending about 25% of income on health care, despite the existence of the Medicare program. By 2025, the average senior will be spending about 35% of income on health care, despite the existence of Medicare. And if we go to a voucher system, often called premium support, where you just get a voucher and you have to add your own money to that to go out and pay a private premium, seniors will be paying more than 40% of their income for health care in 2025. So even if things just continue the way they are, seniors are dipping fairly deep into their pockets to pay for health care costs, and low-income seniors are dipping even deeper than the averages in this slide. The New York Times tells you that if you're planning for retirement and you're going to retire at age 65, you better plan on saving $250,000 to pay for health care costs that will not be covered by the Medicare program, because Medicare will cover only 51% of your health care services. And, of course, the folks in these pictures are very affluent. He's got a hobby of flying his plane. But even affluent people find that the cost of health care and retirement are really substantial and can affect your overall standard of living. If you end up needing nursing home care, the situation is quite a bit worse. Only about 1/4 of all nursing home care in the United States is paid for by the Medicare program. As for the rest, people are generally paying out of pocket all of their assets until they're totally impoverished and Medicaid kicks in. So we really don't have any substantial Medicare coverage for nursing home care, other than, if you get out of the hospital and you need just a little bit of nursing home care for a few months, but thereafter you're on your own until you spin down, become impoverished, and get Medicaid. So it's a problem. Medicare coverage is skimpy. It leaves seniors paying for a large share of their health care costs, particularly of their long-term care costs. Now, there's other things wrong with Medicare as well. Medicare has gone from a really fully public program where it was tax-funded and all of the administration and governance was done in the public sector to an increasingly privatized program where care is delivered by private managed care plans. But privatization is maybe the wrong word, because it's public money with private control. The control is private, but the funding is from taxes and from the public. That's what we mean when we talk about Medicare privatization. Okay. Now, one of the biggest problems with privatization is it means that these Medicare HMOs, also known as Medicare Advantage plans, take a huge bite of the total Medicare dollar as their overhead. In this report from the U.S. Committee on Energy and Commerce, the average Medicare Advantage private plan had an overhead per year per enrollee of over $1,400, just for overhead, $1,400 per enrollee per year, with traditional Medicare having an overhead of about 1/10 as much. So among other things, going to a privatized Medicare program means that we're going to eat up a lot of the Medicare dollar as private plan overhead. One of the surprising things is that despite Medicare's lower overhead, enrollment of Medicare patients in private plans has grown. Now, you would think if we were talking about a strictly free market situation, Medicare, traditional Medicare with its lower overhead would triumph in the marketplace. but that's not true. In fact, the enrollment of Medicare patients in private plans has grown, as demonstrated in this graph. In 2012, about 14 million Medicare seniors are enrolled in the private Medicare Advantage private plan programs. Okay. Now, how does this all work? Well, one issue is cherry picking, or the Medicare Advantage plans selectively enrolled healthier people. But they don't just cherry pick, they spit out the pits. That is, the Medicare Advantage plans selectively recruit healthy seniors, but when those seniors in the HMO get sick, they are sent back into traditional Medicare. And this was documented years ago by some authors in New England Journal of Medicine, and let me explain the graph. Traditional fee-for-service Medicare costs are graphed arbitrarily at 100 in yellow on the left. These authors were able to look at seniors who left traditional Medicare and subsequently enrolled in the Medicare HMO and found that before joining the HMO, they had very low spending only 66% as high as the average for Medicare fee-for-service. These authors were also able to look at folks in the months after they left the Medicare HMO and re-entered traditional Medicare and found that those seniors had health care costs nearly twice the Medicare average, often because they had left the HMO to get elective surgeries or elective mental health care that they needed and couldn't get in the HMO. So cherry picking and spitting out the pits, one way that Medicare HMOs are able to profit off the Medicare HMO program. Part of why they can do this is because it's really only a few sick people who account for most health care spending. I call this the 20-80 rule, that the 20% of people with the highest medical need are responsible for nearly 80% of total health care spending. It's true in the health care system as a whole, and it's true within the Medicare program. What this graph shows is if you take the population and divide it into deciles, 1/10, 1/10, 1/10, 1/10, by the expense, the medical expense experienced by that tenth of the population, about 20% of the population has zero or very little spending in the course of the year. But when you get up into the top 80th and 90th percentile, people are accounting for nearly 80% of all health care spending. The 20-80 rule, 20% of people use 80% of spending. So by avoiding that 20% of the population who's sick in any given year, an HMO can make an awful lot of money off of the Medicare premiums. Now, several authors, including the Government Accounting Office, MedPAC, Commonwealth Fund, Families USA, have pointed out that Congress has been consistently overpaying HMOs relative to what it would cost to care for a similar patient in fee-for-service Medicare. That 100% line would be what it would cost to care for a patient in traditional Medicare, and you'll see in every year since the mid-1990s, Congress has decided to overpay HMOs. But the situation is somewhat worse than depicted in the previous slide because those previous authors ignored the fact that there's an additional overpayment to Medicare HMOs from the Veterans Administration. What am I talking about? When a Medicare HMO enrollee goes to the Veterans Administration hospital, the federal government pays for their care in the Veterans Administration, and that care is never billed back to the HMO. So in effect, the government is paying twice. First, it's paying the premium for the Medicare HMO, and then it's paying a second time for the care of that patient in the VA. And that subsidy from the VA has been rising and currently accounts for more than $3 billion annually. It's about 1/10 of total the VA budget is represented by this subsidy that the VA is giving to the Medicare HMOs through the free care for folks who have Medicare HMO coverage. So when we at PNHP decided to look at all of the types of overpayment to HMOs, all of the ways that Medicare HMOs are overpaid by the Medicare program, this is what we found. First, we found that there's an overpayment because many of those Medicare HMO enrollees get their care for free at the VA, with the government, in fact, paying twice. The pink part of the slide is the cherry picking, which we talked about, that the HMOs selectively enroll folks they can make money off of through their complicated cherry picking. And finally, the part at the top, the yellow part, is something that Congress has legislated. As of 2004, they started saying, we know we're overpaying HMOs. We're going to do it anyway because we think HMOs are a good thing and will improve things for seniors. So it's really only that legislative part, that yellow part, that was addressed in the Affordable Care Act that's been debated in Congress. The overpayment related to VA care and the persistent cherry picking is not being addressed in the current Washington debate. Now, this translates into a huge amount of money in overpayment, about $34 billion in overpayment from the Medicare trust funds to private HMOs in 2012 alone. And $34 billion would go a very long way toward addressing the financial crisis in Medicare. Not all the way, but quite far. It would reduce the deficit in Medicare by about 1/3 with just one single swoop, saying we're not going to overpay HMOs anymore. Sadly, the Obama administration has signaled that they will continue to overpay the HMOs in a ruling by Sebelius that came down last month. Okay. Now, all of this might work out okay if the seniors were going around and saying, well, let me be a good shopper and figure out which HMO is best for me. Maybe they offer some other services that are helpful for me, and I'm going to be an excellent shopper and figure out, how I can do best in traditional Medicare and these HMO plans. It turns out that very few people are able to be good shoppers when it comes to health care. I certainly know for my own family, I sometimes spend hours trying to figure out what's going to be the best and least expensive way for us to buy health insurance. And despite being pretty expert in this, I often at the end of it really can't tell. And apparently that's true generally, because when these researchers look to see if senior citizens were choosing the optimal Part D plan. Remember, the Part D drug plan pays for your drugs. And if you want, you can write out your list of drugs and look them up at the Part D plan and see what your copayment would be, and at least in theory, figure out what was going to be the cheapest plan for you. But it turns out less than 16% of seniors are able to do that, to figure out the cheapest drug plan. And it just speaks to how really difficult it is, nearly impossible, even if you have all your marbles, even if you have the time, even if you can see, even if you can look things up, how extremely difficult it is for people to be good shoppers and choose between plans. The question is, do seniors need choice or do they need guarantees? And this would be pretty good evidence that relying on choice, relying on seniors to be good shoppers and get what's cheapest for them is not really likely to pan out. Okay. There continues to be evidence that the for-profit Medicare HMOs avoid expensive care. This was a study from the JAMA looking at folks with rheumatoid arthritis, and the optimal care for rheumatoid arthritis is frequently something I call a DMARD up there. That's a medical jargon for a disease-modifying agent, a pill or a injection that will actually change your disease, not just cover the symptoms, but change the disease. Obviously, that's optimal treatment, and patients who enter nonprofit HMOs get that optimal treatment 2/3 of the time, whereas if they enter for-profit HMOs, they're much less likely to get that optimal treatment for their arthritis. Okay, let's talk a little bit about Canada. As Ben was alluding to, U.S. Medicare is in some ways a model for a single payer, But, of course, it's one among many payers. There's Medicare, there's Medicaid, there's Medicare HMOs, there's private insurance, there's people paying out of pockets. Canadian Medicare is a true single payer. They use the same name we do, but it's a different program in that it's a true single payer. It covers everyone, okay, and it covers everything. So from the day you're born to the day you died, you're enrolled, and any medically necessary care is covered. It's also in a public service model that restricts profit-making and profiteering. That word's missing there, but a public service model rather than some sort of market choice model. We're public service like the fire department, like the public schools, and we're not a field for profit-making. We've done some work to look at the differences in cost control between the U.S. and Canada, and we look specifically at people 65 and older, and they would be eligible for U.S. Medicare, that's the blue line on the top, or in Canada they'd be eligible for Canadian Medicare. Both government-funded programs, but lo and behold, see how much more effective cost control has been in Canadian Medicare than in the United States. The United States would have saved more than $1 trillion had our Medicare cost control been as effective as cost control in Canada. So things aren't perfect in Canada. Costs have gone up by more than 50%, but meanwhile in the United States they've been doubling and tripling. So much more effective cost control in Canadian Medicare than in U.S. Medicare. Well, how do they do it? Well, some they provide more comprehensive coverage. So we mentioned earlier that U.S. Medicare only pays 51% of the total health expenses of the elderly. Canadian Medicare is paying 79%. So most expenses with the exception of long-term care and some psychological services, but mostly we're looking at long-term care expenses there. So much more comprehensive program and yet better cost control. Part of it, of course, is administrative costs. So overall administrative costs in the United States versus Canada in 2011 on a per capita basis, this is not just Medicare, this is the entire healthcare system, but a per capita basis, 300 million Americans paying an average of nearly $2,000 per capita more just for the paperwork costs of healthcare. And, of course, that's not just the paperwork costs at your insurance company, that's the paperwork costs at your doctor's office who has to bill, dozens of insurance companies and hundreds of different plans. That's the paperwork at the hospital that has to deal with dozens of insurers, hundreds of plans. So the overall savings in administration in Canada are really substantial and a major contributor to their better ability to control costs. But in addition to these large administrative savings, which we've estimated at about 14%, if you do that math, you take 31% administrative costs in the U.S. and subtract about 17% in Canada. In addition to lower administrative costs, Canada has controlled costs through lump sum global budgets for hospitals. So the hospital gets a lump sum and that they negotiate, and then every month 1/12 of that budget appears in the hospital's checking account, okay? And that way you save on administration. The other thing they get is they have this very stringent capital control for new buildings and equipment. That lump sum global budget cannot go to buy a new CAT scan, a new MRI. That budget cannot go to buy a new building. If you want a new building or a new MRI machine, you have to go and make the case and get a separate appropriation from the single payer to buy that new building and equipment. And what that means is you have not just health planning, but health planning with teeth. The single payer, the provincial single payer agency is actually able to make health planning decisions about where new buildings and equipment go. That saves a lot of money. The third factor for the lower costs are the single buyer purchasing power. When a province goes to buy drugs, they say, we're buying billions of dollars worth of drugs. You, the drug companies, need to give us a better price. So Canadians get the exact same drugs that we have in the United States, but they pay about 60 cents on the dollar. They get a 40% discount by using their purchasing power to rein in drug and device prices. And finally, Canada has excluded private insurance, including the private plans such as those that have overcharged the U.S. Medicare program by $34 billion a year, allowing substantial savings in that regard. And back to Ben. He's going to talk to us about the actions for Medicare's birthday. Ben, you take it from here.
Okay. Well, thanks so much. And we're going to have time for questions in a minute, and I'll describe how to sort of raise your questions. But first, I just want to let you all know that every year Healthcare Now uses Medicare's Anniversary as an occasion to do a series of actions for single-payer healthcare around the country. So many years we've had over 50 actions across the country. We have some groups that are very large single-payer groups in different states, and some are very small, so the actions look really different. We're going to have rallies in some cities. We're going to have folks in smaller groups just, doing outreach, collecting signatures at farm stands, for example, doing a visibility, doing a house party, showing a movie about our healthcare system or Canada's healthcare system. Any of these can be great actions. A lot of folks have taken birthday cakes or birthday cupcakes to their legislators, asked them to support single-payer healthcare. So really, this is we wanted to give everyone dig in a little bit more in the details and talk about how important single-payer healthcare is, not just for those under 65, but also for seniors who show up on paper as universally covered with insurance, but actually face significant cost and access issues. So single-payer is really an important issue for seniors and for saving our Medicare program as well as for the rest of the country. So if you go to healthcarenow.org, right in the front page, there's going to be this big orange box, and there'll be links for you to get involved to see where actions are already happening or to list your action, where you're doing it. If you can do anything, no matter how small it is, you'll be part of a larger movement, and we can try and move this political project forward. So we're going to take questions. We're going to stop at 2 p.m. Eastern Time on the dot. So we have about a little over 20 minutes to take questions and to have answers and to get a little conversation going here. I would prefer if you write your questions into the webinar box. And right now we have more people on the conference call than a few more people on the conference call than we do in the webinar. So you can, in the email announcement you got, if you click on the link to join the webinar, that's the best way to get in. There's a little Q&A box right along the bottom under the slides, and you can put your questions in there and they'll show up, and Dr. Woolhandler and myself will see them and we can answer some of them. If you're only on the conference call and you absolutely cannot enter your questions into the webinar, you can press 5* and your hand will go up and we can actually take a question from you by audio, but I would really prefer if everyone types the questions in the webinar. And if you're confused about that, you can ask our tech person, Ben Rock, who I want to thank also so much for his help setting this webinar up. So go ahead, ask any questions you have. We have a first question, which is, why did the Obama administration increase Medicare Advantage payments, and what effect might this have on financing over, say, the next 10 years? Steffi, do you have any response to that?
The Obama administration was under a lot of pressure from the insurance industry to increase the payments, and I think we in the single-payer movement were not able to put effective pressure on him from the other direction. So certainly increasing the Medicare Advantage payments will continue a bad situation in which the Medicare HMOs are overpaid and are really draining the Medicare trust funds through their overpayment.
Yeah, and my understanding is that the Affordable Care Act was supposed to reduce those overpayments to Medicare Advantage plans, but the administration has been reneging somewhat on that and has not been increasing it. Has not been decreasing those payments as much as it promised to. We have another question. This is a very functional question. Will this presentation be available in writing? The answer is yes. We will have the whole audio connected with the slides as a video that will go up online afterwards. So anyone who missed this presentation can see it later, and you can refer back to it if you like. We have a question from Patty Morris. What will happen as more extremely expensive meds for specific conditions like cystic fibrosis come to the market? will they simply be rejected from Canadian drug formulary if it's too expensive, even if life-changing or life-saving? The UK has had issues like that with a $300,000 new drug for some CF patients. So I think this is a question about concern if we move to a single-payer system, including our Medicare population. Would it have an impact on access to drugs?
Okay. Well, in Canada, there have not been major issues in this regard. That is, if a drug is truly life-changing or life-saving, it's covered. Frankly, even in the UK, they have an agency that's supposed to tell whether the drug is enough of an improvement over the existing drugs to gain approval. And generally, there are alternative drugs available when a drug is rejected in the UK. Part of the problem, of course, is the pharmaceutical industry is really profiteering on these drugs. Often they could charge a whole lot less for these drugs, but they feel like it's a life or death situation, and they have the power to really overcharge people for them. So there are two problems here. There's the fact that the pharmaceutical industry is overcharging, and then there's the issue that some of these drugs really are expensive, and you need to figure out whether they're worth it or not.
Okay, we have one comment. It says, just an endorsement as a Canadian living in the U.S. We find ourselves compelled to go back to Canada as we approach 65, and we resent the fact that the Canadian system is so maligned by the U.S. media. So thanks for that comment. I have a question. A healthcare consultant has suggested that support for single payer will hinge on the success of the Affordable Care Act. Do you agree?
Well, not really. I mean, the Affordable Care Act is, at best, going to be a very halfway measure. The Congressional Budget Office is now predicting that 31 million people, will remain uninsured after the Affordable Care Act is fully implemented. So it's clearly not universal. Many of the people who get insurance will see a big improvement in their life, but some people will end up with insurance that's so skimpy they still can't afford care. Again, it may be an improvement, but it's certainly not a solution. So I don't think the case for single payer is particularly strengthened or weakened by what happens with the Affordable Care Act. I do think we're going to see a real upsurge in interest in single payer as the effects of the Affordable Care Act become evident, as people see what the new insurance is like, see what it costs, see what happens in terms of the uninsured. It will become much clearer to people that we haven't solved the problem and we need to replace the Affordable Care Act with single payer.
Yeah, I think I would just add to that. I mean, when the Supreme Court was reviewing the Affordable Care Act and people thought that they might strike down the entire Affordable Care Act, you may remember that the press was filled with commentary that, the Democratic Party would have to push for single payer after if the Affordable Care Act failed. And I don't think that's true either. I think the real driving force between a growing single payer movement is both our organizing as a movement, but also rising healthcare costs, which are affecting every single household and every municipal, state, and federal budget and business budget. So, and the Affordable Care Act does very, very, very little to affect those costs, which are going to continue to rise. So that's a great question. Next question is, how would you ensure coverage for those suffering from occupational diseases, 90% of whom are never covered by workers' comp? Not certain if this is a Medicare-related question.
Well, certainly under a single-payer system, everyone would be covered whether it was work-related or not. If the workplace is unsafe, then that needs to be addressed as well. And the workers' comp system was never a very good way of addressing workplace safety. You're much better off with a real regulatory approach like OSHA, going in there and setting rules and inspecting and making sure things are really safe. But the advantage of single payer is you don't have to have a fight about whether it's work-related or not. If you have a medical problem, it would automatically be covered.
Mm-hmm. We have another comment and question. We've been showing the healthcare movie narrated by Kiefer Sutherland in house parties, colleges, churches, political clubs, and union halls with fantastic town hall discussions to follow. This is important to preach to the choir as well as to bring in new members to the movement. Any other suggestions? I think that's a great tool that you've been using. For those who haven't heard about it, the Healthcare Movie is a documentary about the Canadian healthcare single-payer healthcare system and its creation and sort of the politics around that. The actor Kiefer Sutherland, actually his grandfather, Tommy Douglas, is credited with leading the first creation of the first single-payer system in Saskatchewan. I can give you another suggestion. We've actually been working with an actor who's been doing this one-man play called Mercy Killers, which there's a few states who have literally invited him to just come out to their state and do a tour of 3 or 4 showings. And that has actually brought in a lot of people who are not sort of already in the single-payer movement, don't really know anything about single-payer necessarily, but it was a great sort of entree for them. And, just in general, by plugging into the communities that you already belong to, I think all of us are capable of getting out there. I don't know if you had anything to add to that, Dr. Woolhandler.
No, I agree completely. We need to keep the single-payer concept going so that as the problems in Obamacare become evident, people just don't get discouraged and say, see, we tried it and it didn't work, that there's a positive vision, not of repealing Obamacare, but replacing it with something better.
Mm-hmm. Great. And we have a question, again, saying, can we have this presentation audio and visual for a July 30th public program? The answer is yes. We're going to put the audio and the slideshows up on the web, so they'll be available for streaming. And it's a great idea. It would be an easy Medicare Anniversary action if you just wanted to show this slideshow to a more broader audience. We have another question. Please explain the impact on safety net hospitals that are reliant on disproportionate share hospital funds. This is somewhat of a technical question. Disproportionate share hospital funds, these are safety net payments that occur through Medicare and some other programs to hospitals that treat low-income and low-reimbursement communities, many of whom have no insurance or poorly paying insurance. Do you want to tackle this one?
Sure. Well, one of the myths about Obamacare was that it would cover 100% of the uninsured and therefore we wouldn't need safety net anymore. And, of course, that is not true. There will be 30 million uninsured under Obamacare, and many more people, low-income people, are still having trouble affording care and need to rely on the safety net. I might also add that even if you have good insurance, if you have certain types of stigmatized diseases, you may still need to rely on the safety net. So if you need a mental health care or substance abuse care, those folks are seldom able to get that in the private sector and have to rely on the safety net, even if they have money, even if they have insurance. So a lot of people, so we still need the safety net. The need for the safety net does not go away under Obamacare. And yet the Obamacare bill cuts $34 billion from the DISH payments, that is money that the federal government was giving directly to safety net hospitals. So that's one of the worst things, to be honest, in the Obamacare bill, is that it did take money away from the safety net institutions, which we will continue to need for the foreseeable future.
Mm-hmm. Good question. Another question, do Canadians pay for prescription drugs, and does it vary by province?
It varies by province. Poor people don't have to pay for drugs, and in some places elderly people neither, but the coverage of drugs does vary by province. Affording drugs continues to be a pretty serious problem in Canada. So we've been doing some work on medical bills in Canada, and the biggest problem that Canadians have is paying for their drugs. The second biggest problem is paying for dental care. And, of course, neither of those things are uniformly covered in Canada. Canadians really don't have any problem paying for doctor's care or hospital care because that's fully covered.
Mm-hmm. Next question, is it true that we will not have a national health plan until we have a single-payer system in at least one state? I think there's probably multiple different answers to that. Canada did end up with a national single-payer healthcare system by first one province adopting it and then others, but many other countries have got it through just a national bill. So I think the answer is to support all of the single-payer organizing that's going on around the country right now. We have another question. Is this situation with traditional Medicare getting hit comparable to what would happen in a system with a public option amidst private plans? That's a very good question.
Well, it's actually a very good question because what's going on now is that there's a traditional Medicare program and there's these private plans. And the private plans find it's very profitable for them if they can push their unprofitable patients back onto traditional Medicare. So I think that's exactly what would happen if you had a public option for people under the age of 65, that the high-cost patients would be pushed back to the public option, and it would make it more profitable for the private plans and more expensive for the taxpayers.
Next question, would H.R. 676 give us a Canadian-style healthcare system? I think the answer is somewhat. H.R. 676, this is the National Single-Payer Bill that's sponsored by Representative John Conyers. Unlike Canada, H.R. 676 would give us a national single-payer plan. It wouldn't be state by state, and I believe it does cover prescription drugs, which varies province by province, as we just discussed in Canada. Another question, how do they justify the overpayments to Medicare Advantage plans given all the cuts in health care?
Well, how do they justify it? The part of the overpayment is hidden, right? So part of the overpayment has to do with cherry picking by the private plans. The cherry picking is, at least in theory, illegal, but they do it anyway, and there's good evidence from the National Bureau of Economic Research and other places that they're cherry picking to this day. The federal government kind of chases after them and tries to do risk adjustment, but every time the federal government does a risk adjustment, they figure out a new way to cherry pick. So part of it's cherry picking. Part of it is this VA care, that the Medicare HMO enrollees get free care in the VA. But some of it Congress has decided on. Congress has just decided it's going to pay the for-profit HMO industry more. They say that's so they can provide additional benefits. And, sometimes there are additional benefits, a pair of reading glasses or cheaper drug co-payments or something. But when the Congressional Budget Office has looked at this, very little of the overpayment ends up going for additional services. Most of it ends up going for overhead and for profits.
Next question is, how can we make this not only an issue affecting seniors, but an issue affecting those under 65 years of age?
Well, I'm happy to take that. I think a lot of people care about seniors and care about the spending for seniors. So, and most people hope to someday become a senior themselves. So I do think Medicare is an issue for everyone. I don't think we've had that much trouble convincing younger people to care about the future of Medicare. Often the politicians try to undermine that, and they say, the greedy geezers like me, who old people who are trying to grab all the money. But politicians say that, but I don't hear the American people saying that. I find most people are quite supportive of the idea that senior citizens do need health protection, and that they personally want to have that health protection when they retire as well.
Mm-hmm. We've got about 5 more minutes left for these questions. We've got some great questions here. Next one is, are there any provisions in the Affordable Care Act for controlling new healthcare facilities or equipment? I live in a town of 30,000, and 2 hospitals seem to be in an arms race for new MRIs, cardiac care units, et cetera.
No, there's no provision in the Affordable Care Act for controlling new capital. That's a big problem with it.
Mm-hmm. Good question, though. Next one is, how do we change public opinion so that people feel health care is a right, not a privilege, in the same way public schools are for all people living in America? And I think, the short answer is that we have one public opinion, almost every public opinion poll asking the American public, do they support single-payer health care? Even when they ask, do folks support socialized medicine, which is not what single-payer is, but it's sometimes how single-payer is attacked. Still a majority say yes. Even if you use language, do you want the government to publicly guarantee access to health care for all residents? A majority support it. So I think we do have public opinion on our side. That doesn't mean that there's a deep understanding of how single-payer works or how our current healthcare system works. But it does mean that it's not public opinion that's the problem. It's our political system that's the problem. And that's a little even harder to change than public opinion. Next question. This is right up your alley. Why aren't more physicians endorsing the single-payer system?
Well, a lot of physicians do endorse single-payer system. When we've done surveys, we tend to find a majority, sometimes as many as 2/3, saying they support national health insurance. And when we drill down and say, well, what kind of national health insurance, at least half of those will say single-payer. So we are making some progress in the physician community and educating people about the single-payer system. Do we need to be doing more? Absolutely, and our group, Physicians for a National Health Program, spends an awful lot of our time and effort working on that.
Great. Next question is, how can we use the Affordable Care Act to help organize for single-payer right now and into the future? And I can tell you from Healthcare Now's perspective, we're planning in August to release a single-payer activist guide to the Affordable Care Act. And along with that, we're probably going to be doing little sort of forums around the country, trainings, where folks can get together and talk about, what the Affordable Care Act, if it does nothing else, it will keep healthcare on the agenda, and there'll be lots of fights over access to care and costs. So it is going to create a lot of organizing opportunities to try and build the movement for single-payer healthcare. So I think it's important that we use it as an opportunity to grow and to build this movement and to try and move Congress to the next step, which is just making healthcare right and controlling costs. But it does have the potential also to marginalize the single-payer movement, since a lot of our natural allies will want to just focus on implementation issues and sort of ignore single-payer healthcare and arriving at a sustainable solution. I don't know if I know that Physicians for a National Health Program will be very engaged in all that as well.
Certainly.
Yeah. Another question, what's the situation in Vermont where they're trying to implement a statewide single-payer system? How is the insurance industry reacting? Best of my understanding is that they were a little slow to react, but Med has started pouring into Vermont to try and undermine that system. Vermont didn't pass a single-payer bill. It passed sort of a series of steps that was designed to take the state toward implementing a single-payer system by 2017. They still have a few big hurdles. They have to pass a separate financing bill. So there's still a real on-the-ground fight there. And there's growing spending and mobilization against them in Vermont. So I think we need to keep an eye on that and try and provide solidarity support wherever we can. Next question. At our current spending level, and we have time for maybe a couple more questions. I'm sorry we're not going to get to everyone. I think what we'll do is we'll write down all these questions, and we can include our answers in the published version. We'll have written answers possibly. They may have to be brief, but we can get to a couple more now. At our current spending level, but under a more efficient single-payer system, would we have enough funds available to prevent the delays for non-urgent services, queues, in other words, such as are seen in Canada and Great Britain?
Well, I think so. The United States is currently spending about 40% more per capita than Canada. So when we talk about a Canadian-style system, we should be thinking about Canada Deluxe. That is, with the kind of efficiency and fairness and quality they have in Canada, but with even more resources available so that people don't have to do any queuing. I would urge people concerned about queuing to look on the websites of the Canadian provinces, because they do keep like real-time records of the waiting list, and they'll tell you how long the waiting list is. And if you look there, you'll be surprised that there are actually very few waiting lists of longer than a couple of weeks. Yeah, if you want to get one specific surgeon, you might wait several months. That's actually true in the United States as well. But if you're willing to take, the first available qualified surgeon to do your surgery, often the waits are quite short, on the order of 7 or 8 days, or perhaps a couple of weeks.
All right, so we've just reached the end of our time. Those were phenomenal questions. Thanks, everyone, so much for joining us. We will make this available online again, and I encourage you to visit healthcarenow.org and pnhp.org. Get involved, organize Medicare's Anniversary Action on July 30th, and we will think about doing another one of these webinars soon if people enjoyed it. So we'd also appreciate your feedback on whether this was a helpful forum and format for folks to get more information. So take care, and thanks so much.